You're listening to the Physio Matters Podcast this month in association with the ATOCP, and this is session 24. Welcome back for session 24 of the Physio Matters podcast. For many of you, it couldn't come soon enough. Since leaving it on a cliffhanger last month, we've been inundated with requests for insights, and so the wait is over. Just a reminder, each podcast will be released on the first Sunday of every month, except perhaps session 25, which is a rather juicy review of 2015, both in terms of the podcast but also the changing climate within MSK practice. It's going to be myself and the rest of the Physio Matters team chewing the fat over what will be a few beers at our Christmas party. But before that, here's the second part of mine and Rob Tyer's interview with Sallie Lamb, discussing protocols, regulation and for the most part acute whiplash research. And believe me, this time it builds to a climax rather than a cliffhanger. I'll see you at the other side. Post-operative protocols, procedures and policies remain commonplace across orthopaedic practice, although they're increasingly written as a collaborative MDT, most of which we've encountered seem quite generic with little scope for individualisation. We've kind of alluded to it earlier as to how these things get formed on long-standing assumptions. In research, there is a need for protocol-based proceedings, and that needs to be formalised to some degree. When that's then extrapolated into clinical practice, it seems that can be somewhat restrictive. How do you see that being better translated?
So, when we run a trial, generally what we are doing is we're developing a new intervention that may or may not bring new clinical skills, but it has to be protocolized. And that's a legitimacy requirement. So, for instance, our colleagues in medicine wouldn't give a drug without having a protocol for the application, so they know what drug dose they're going to give, they know how often they'll give it, what strength, and then when they report the findings of their study, their colleagues can see clearly what's been happening, so they can replicate that well. So it's really a difficult issue for people who work on trials. So one of the areas that we have a lot of difficulty with is when we first go in to do a trial and we're asking clinical colleagues to collaborate with us on delivering treatment. Quite often we get a kickback around the protocol of the protocolization of the intervention. And I think it's because people don't really realise the importance of it. And also there's some kind of, I think it's a little bit, it goes against autonomous practice for some reason. I can't quite understand why, but maybe people will understand a little bit more when I elaborate. So when we do an exercise trial, just like if you did a drug trial, we pre-specify the dose that we want to achieve within the trial. It's the target dose. And we find, particularly in exercise trials, that very often therapists are very conservative. They will rather under-push a patient rather than over-push them because they have fear of adverse things happening. And in fact, the literature says that really these adverse events, serious adverse events from these types of interventions are rare, but it holds therapists back, and I think it's kind of somewhat historic and not updated in their own mind. So we will kind of specify a protocol quite clearly. You will please assess the patient in this way. You will please, from these assessments, make these types of decisions, and then you will please apply an intervention with this amount of load, with this number of reps, and this is how you will progress it over time. So going back to the drug thing, it's about the amount, the intensity, the frequency, all of those different types of things. How do you progress it? How do you regress it? And I think many of our clinical colleagues find that difficult. But it's absolutely essential because when we come to want to implement an intervention, we have to be able to say to people, it's no good us saying, oh yeah, exercise works for rheumatoid arthritis of the hand. No, it's not that. This dose of exercise applied in this way works for rheumatoid arthritis of the hand, because one of the kind of things that we do as researchers is, my own area of research, I keep well on top of the literature relating to exercise physiology and strength training and all different types of training, because I want to get the most potent and effective and efficient type of training into clinical practice. So these then protocols are the kind of recipe, as it were, for doing this intervention. And I think that it is difficult for people to sometimes understand why things are like that. Why does this protocol look like this? Why am I being asked to do something that I haven't clinically reasoned necessarily and kind of built up myself, which is the way in which we practice? And I'm afraid in some areas it's because the clinical reasoning of the majority of the physiotherapy community is not able to keep up with the developments in physiology. So if I was still working in clinical practice, I trained quite a long time ago. Can't remember exactly when, but it is over 20 years ago. Had I stayed in clinical practice, I wouldn't know anything about the modern ways of exercise prescription. And in fact, in my training, the training that we had in exercise prescription was really poor, and that's a fundamental part of our clinical practice. So this is why you end up with protocols in research. I'm not sure that it entirely answers your question.
No, it certainly does. I think, let me maybe elaborate on my fears of when that does get translated. So the protectiveness of autonomy, sometimes people, I imagine, do bite back, but my bigger concern is it withdraws accountability on that clinical situation. So if say there is a protocol in place, not necessarily extrapolated from research, but say there's a protocol in place post-operatively that's dictated to partly by research and partly by these assumptions that we find, then never mind autonomy, the accountability of the physiotherapist acting within that. If something goes wrong, or if something's not progressing well, or they get a poor outcome, they're arms in the air and blameless. I was still working by the protocol. I did everything I can within the parameters set. So both autonomy and accountability are redundant.
Yeah, and I come back to you and say that within the trials that we do, of course we recognise the fact that physiotherapists have to moderate what they do. Always the person who takes accountability within a trial for the decision they make in the clinical setting is the physiotherapist who is in that clinical setting, and that is golden to us. So what we provide is the protocol that we want them to achieve, and so we train people up in these kind of techniques, and we know what we're training to. So when we get the physiotherapists in, they come in and we'll say, okay, this is the paradigm that we're training you to, this is the background knowledge, this is the things we want you to try and achieve, this is the reasons why. For instance, we know a muscle doesn't strengthen unless you challenge it enough. We also know that that's difficult because patients come with pain, patients might come with comorbidity. For instance, we're doing a study, high-intensity exercise training in dementia. These patients come with cardiovascular risk factors. I cannot dictate to a physiotherapist, right, you're to train them at that intensity, and that patient gets angina. I mean, that's bonkers. And of course, they're expected to moderate. That's part of the intervention. But nevertheless, we still kind of have this underlying principle that this is what we want you to achieve, and these are the reasons why. And when we report our interventions, we do actually have a look at how much does compliance to the intervention matter in all of this. And that provides interesting insights as well. I think it's going to provide more interesting insights as we go over time, and we'll learn more about it. But for instance, in the strengthening and stretching of rheumatoid arthritis exercises, SARA trial, we know that the physiotherapists certainly prescribed the exercise and regressed it or progressed it, because we're all physiotherapists who design these interventions. We all love the profession. We all, kind of know and understand about autonomy and responsibility and the joy that comes from doing clinical practice. So we, we build this into the intervention that's there. But nevertheless, we want it to be good. We do know that, patients actually, when we ask them to do things in a certain way, don't do it in the way we want. and they still get the effects, and we've captured that type of thing. And we generally try to measure whether or not therapists have done what we want, and we have a look at that as well, and we're beginning to get more and more evidence about what really matters.
I think from with my inherent bias towards exercise prescription, with the background that I've come from, we were having this discussion actually yesterday about how important is the dose response versus how important is the perceived effort that's being applied by the person. So is it essential they reach 12 repetitions, or is it essential they reach a rate of perceived exertion? And I know there was a paper that maybe wasn't the as well constructed as we'd like it to be, but I think it was the first of its kind, investigating the kinesiophobic beliefs of the physiotherapist on the patient.
Yes.
And they were talking about how historically as physios we are maybe more worried about the consequences of pushing that patient than the patient is sometimes, and that has negative effects. And obviously, as we've discussed, and I don't want to sort of bang the drum about pain being a multi-centered problem, but I think sometimes is it important to get them reaching that repetition, or is it important for them just to be participating in the activity? Because compliance is such a difficult thing in all physiotherapy intervention, and it's very easy to blame patients for not complying and very difficult to reflect on your ability as a physio to encourage compliance. So to summarise that really long-winded question would be, does it really matter how many repetitions they do, or is it just that they need to have a rate of exertion?
Your question is quite deep, and it goes in many different directions.
Because it took 20 minutes.
Generally, in the trials that we do, we use perceived exertion, because we know that perceived exertion for the majority of people, both in terms of strength training and in terms of aerobic conditioning, correlates reasonably well with the physiological kind of underpinning. So there's people who are working at the somewhat hard threshold, are working at the right level of our percentage of RPM, a repetition maximum, or aerobic capacity that we think they should be doing. I think the great thing with the perceived exertion thing is it's, I think, more comfortable. I think it's easier for patients to use, and I think also it probably enables physiotherapists just to be able to moderate through those other things that the researcher who's not in the room can't see. So for instance, if you're somebody with a lot of comorbid conditions, I'm trying to think of an example. You might have somebody who's relatively strong in the limb, but actually has, kind of like a chronic respiratory disease or COPD.
Classically going into a class where they're expected to do squatting from a chair.
And of course, what the perceived exertion does is it moderates all of that, whereas the RPM type of measure is purely focused on, what you're achieving here. And there is the possibility, if you were kind of not of sound mind, that one could push a patient thinking, oh yeah, I've got to achieve this RPM for a certain number of reps, and have the patient conk out because actually you've not looked at the perceived exertion overall. So we tend to use perceived exertion at the end of the day, but we are confident that in the majority of cases that it correlates reasonably well.
And I think that's supported in some of the literature as well, with the modified Borg scale and the effect of people reaching heart rate maximum thresholds. Yeah. So would it be fair to say then that actually these protocols are not as rigid and they're more semi-structured when you have the confidence in the clinician that they have a background in exercise prescription and can sort of act on these variables within clinic?
I think with the protocols, we make no assumptions really, and we can't, about the knowledge of the physiotherapist that applies them. We do know, because we are physiotherapists, we know the type of skill set and the type of knowledge that people have, but we're not in the room, and we don't dictate, and we're not giving the treatment. We're asking somebody else to give a treatment, and that person has autonomy and responsibility. So I think the protocols that we use are fair, and I don't think people should feel threatened by them. We have thought carefully about these types of issues. They do push therapists, though. I think that is something. I mean, I've had some colleagues physiotherapy is a great community. I have some people who I trained with at Salford School of Technology who now work on delivering interventions in our trials. So these are very old friends of mine. And they will say to me, "Oh, I can't stand your protocol." They say things to me that other people wouldn't say. It's kind of like, and they say these types of things. And they find it very hard when they come in to understand why. But I think when they become comfortable, it's something we're not comfortable with, then they realise why it's important.
Because my sort of potential comeback on that is that physiotherapists are perceived to be industry experts in exercise prescription when actually that is not often the case. So then the counter argument to that from a financial point of view is, are we too expensive to be implementing these protocols, and should it then be disseminated to an exercise professional?
I think that we should. There's certain areas of clinical practice that I think we should kind of gain some traction on, and I think that exercise is one of them, and I think that research helps us to gain traction. So I know I've been criticised for going, some physiotherapists don't feel that we should be doing research on cognitive behavioural stuff, and that physiotherapists shouldn't do cognitive behavioural interventions. To me, that's nonsense. It's embedded within our clinical practice to motivate patients, to use techniques to help them to become more active, to understand tips for helping people be more active even though they've got pain. That's completely within our area of practice, and we should be kind of extending and saying, yes, here's a physiotherapist-led cognitive behavioural intervention for low back pain. The profession, to me, should be grasping that and saying, yes, these are the new parts of our practice. It's formalising areas that we have expertise in. But we get some kickback by people saying, oh, no, that's not within our scope of practice. We've got to kind of change. And I think this thing about exercise is we may not oversee every little bit that the patient does, but we are the profession that has the expertise that brings together, or should have the expertise that brings together exercise prescription and disease. Because there is a body of people who obviously are very experienced and expert in prescribing to healthy individuals, and they do a great job. But do they have the capacity to, instance, manage a person with dementia, to understand how to get that person with dementia to exercise, to understand all of the difficult health problems that they come along with and how you moderate a protocol? No, they don't. And that's where our unique expertise lies. So I think we should be grasping this. And I grasp it through research, and that's why I do the research in the areas I do, because I think it lays down each of these trials that we do is a physiotherapist-led intervention, and that puts a stake down for us when we have an effective intervention. And I really hope the profession sees that we do it. I mean, it's one motivation for doing it, is that we kind of claim, or I shouldn't say claim territory, I should say more like demonstrate our expertise, which I think is unique.
Assuming some ownership over these things and putting ourselves at the top. Not saying we're the only people that can do it, but as far as science goes, we want to be the benchmark.
We are the only people who really bring together, kind of expertise of being able to do this where there's very complex or even not so complex health problems. Kind of like my area of clinical practice is older people, and exercise is a really potent intervention. If you look at sarcopenia and age-related loss of muscle, it's really important. But you've got a very challenging person in front of you, kind of hip fracture, Parkinson's, probably a couple of other comorbidities, can't see very well. Your average exercise technician down in the local gym is not going to really want to...
Often a lot of people, even in the non-older population, you want to call that, are turned away because of these comorbidities.
Yeah. And they shouldn't be, because it's vitally important. If you address muscle wastage, in older people, we know that there's a good scientific basis. Do we know exactly how to do it? Probably not. We've still got quite a lot to learn, but it's very important.
Fantastic. And we've already sort of touched on the idea that we may be a bit risk averse, and we don't push people enough. And there's been a long assumption of this protective, caring sort of history in which we were founded both as a profession and also medically in nursing and through medical care. It's always been that looking after style aversion to pushing people. So we wanted to just explore an example independent of your research, really, in that total hip replacements have a long-standing history of not flexing the hip beyond 90 degrees, not crossing your legs, and particularly being careful not to twist on a weight-bearing limb. Now, we've myself and Rob have had a little delve into the research there, and it turns out that realistically we're finding that they're probably assumptions that aren't founded in evidence currently.
Yeah, the two systematic appraisals that I'm sure we can put hyperlinks to on the podcast newsletter suggest that actually that they have a deleterious effect on longer term outcomes, and who knows the mechanism of that at this stage, but it certainly encourages us to think beyond the whole laying down of restrictions.
Yeah, to then pose that finding, not specifically but generally, onto how's that happened and how have we made that mistake for so long, and then more importantly, now that we know that and that's good science, how are we going to best integrate that into making sure that these deleterious effects on a very vulnerable population are nipped in the bud as quickly as possible?
I think it happens because people form logic models, clinical reasoning models, whatever you like, about interventions. And I think in particular this issue around hip replacements, it's a very mechanical model, and you can see orthopedic surgeons, they're mechanical type of folks, and this intuitive kind of, if you were to bend this to 90 degrees, that's a mechanical action, and you can see weakness and things start popping out. I think that fits into a logic model that then isn't challenged. And, we all come to a situation with a logic, particularly we come to a situation in which, say, there isn't any evidence and we start to try to apply, we have to pull information from somewhere. So, I'm very cognizant of the fact that healthcare professionals very often have to operate in an area where they don't have any evidence. And also, there's some areas where really there's not worth getting any evidence. So somebody has to come and get a patient out of bed. They don't need a randomised controlled trial on it. That has to be done. So there's certain things that don't need deconstructing, but there are some things that get constructed in the absence of evidence, whether that be the mechanistic evidence, or actually the kind of evidence that comes from studying patients over time. And I think this issue about restricting people is really interesting, and I don't think probably we will have heard the end of it. To me, it is interesting to observe in clinical practice that you can see patients, for instance, patients with dementia, who do the most amazing things on a hemiarthroplasty or a total arthroplasty in the first few days after they've had it put in, and they don't have a bad effect. I mean, sometimes they do, but sometimes a lot of people do. So I kind of have always thought that we are over-restrictive, and I'm really interested to hear about your systematic reviews. I mean, I think that's really interesting stuff, because I do think we place restrictions on people, and perhaps those restrictions are right or wrong in the short term. I don't know what's in the systematic review, but this issue of not lifting restrictions, of leaving patients with this hovering thought that this hip might dislocate, 6 years down the line because they bent their leg to 90 degrees. Of course that's going to frighten people, and of course they're not going to get out of the hip replacement what they went into it for in the first place. So I think it's a really interesting area. I don't know the research well, but again, it's another area where hopefully research will challenge, a little bit like the CAST trial did, the conceived wisdom of what we do in clinical practice. And I think it's really interesting. I can understand it's destabilising and it's a little bit threatening for people, but we should just reflect. it doesn't always mean change, but we should just think, that's interesting. I wonder what that's about. And that's how research starts, and it does come full circle.
I think that one of the things that we'll probably elaborate more on later on, especially with the MINT trial, is that maybe there is a little bit of feeling of people being quite precious about their role as a physio, and that it's a false dichotomy whereby if we say that we shouldn't be doing something, then that automatically creates a knee-jerk reaction from some clinicians that say, well, do we need to exist then? I think what I find quite refreshing about the research is that it actually just narrows our focus onto the stuff that really matters, and that we can be really instrumental in applying change in that area. Like you say, it's important for physios to be involved in research. Like you've pushed out the distal radius fracture research, which suggested that actually the older K-wiring procedure is better than the newer, more expensive procedures, and some of the non-weight bearing statuses following calcaneal fractures it doesn't need to have a surgical intervention. So there are some real shakes at the foundations of what is current clinical practice, and I wonder where that leads us into the future of where to sort of direct our attention.
Yeah, I discussed a little bit earlier that I think our profession has the maturity, at least I hope has the maturity, to act on evidence, both positive and negative, and see it as an opportunity to start to do new things, and recognise that we do live in this finite financial thing. I mean, I am astounded by the pressures physiotherapists are under, and I can see that the thought of adding more and more things is really just very difficult for people. But the way we do that is by getting rid of some of the things that don't work and investing our time into those things that do. And I'm fundamentally of that belief, and I think that's what the evidence base that's emerging will help us to do over time. I think the problem is we're early on in the picture now, so kind of the odd trial that comes out, I think it was, kind of astounding. There was a physiotherapy trial in the British Medical Journal. And, kind of it said a bad thing about physio. It probably wasn't the best place to start, but that's research. And
that's science.
It's science. And things have things have moved on from there now. And I think it's good for us. We should be proud of, as a profession, that we can do that, because there's many professions who can't do it. Both we can do it in terms of the skill base we have, but in terms of the maturity we have, and we've engaged with it and said, right, this is how our profession is based. We are signed up to evidence. And I'm going to be, of course, debating that in a few weeks at Congress, I think, with some colleagues who think we shouldn't be evidence-based.
Fantastic. No, I'm looking forward to hearing the fallout of that. Inevitably there will be some dramas, and looking forward to that. But the discussion around physiotherapists being somewhat fearful of doing less, or we've talked earlier about fearful of change, fearful of integration, or fearful of modernisation, it does sort of bring us really nicely into what we could arguably be called your most famous piece of work, partly through drama, which you were involved in. Now that is, of course, the MINT trial. Now I can't talk about the MINT trial without asking whether the Lamb and Mint analogy was accidental or not. So can we first put a line in the sand?
Yeah, it was entirely accidental. And I have to say, always in these research studies, I never come up with a trial acronym myself. I'm totally hopeless at doing these things.
Because there's quite a few, isn't there?
There are. Well, there's Sarah, which is, people call me Sally, but actually my official name is Sarah. And people kind of think that I've got some massive ego, that I've called a trial after my own name. In fact, my colleague Mark Williams, he said, strengthening and stretching for rheumatoid arthritis of the hand, Sarah, and likewise MINT. I think Mark might even have come up with that one as well, managing injuries of the neck trial. So no, it's not.
There
It's not some weird thing I'm doing.
It's all right. I mean, if anything, if we do, it's something we've not built a massive amount of suspense around. But I bet that would have been the number one question if we'd have asked our listeners what to ask Sallie Lamb. I think that would have been up there really as to whether that was accidental or not. So thanks for clarifying that. But generally, that trial, and allow me to summarise, and I hope I don't get it wrong to do so. It concluded that there wasn't a great deal of difference in outcomes, namely pain, function and cost effectiveness, between a single advice session and a course of what was then considered usual care of up to 6 sessions of physiotherapy. Caveat being that there was the usual care reduced work-related absence and demonstrated some short-term improvements compared to the single advice session. As lead author, particularly recognising that this was a 2012 paper, what do you feel that this trial tells us, and what changes do you feel it should have provoked?
So the MINT trial was a very large trial, and it was a trial of a care pathway. So what we were trying to capture in that trial, and actually I think we captured reasonably well, was the acute management pathway of whiplash injuries. I think, to me, what it shows is that whiplash injuries recover. Now, I'm not a person who believes that, kind of people with whiplash are malingerers. I have done clinical practice. I have seen the kind of muscle spasm, the lack of movement, the pain. I've seen all of that. I think what this trial tells us is that process has a natural history of recovery, which is really good. The great majority of people recover from this injury. And that applying physiotherapy, other than an advisory session, so, we can't say that physiotherapy doesn't work full stop, because the advisory session was given by a physiotherapist for the people who... So we kind of took people as they come through the emergency door again, and we trained emergency departments to give a certain type of psychologically structured advice versus usual care advice in ED, which, kind of is probably not very much, to be quite honest with you. There was no difference there. And then in both arms of the trial, we allowed patients who were still struggling at 3 weeks to come back in. And that's kind of broadly reflective of what's going to happen. You're kind of going to toddle off, and if you've still got a problem, you're going to reappear in the system somehow around about that time point. And it's not unreasonable to think you'd have gone back to your GP and they'll have sent you up to have some physio. And then we kind of randomised patients again to whether or not we gave them reinforcement of the advice and an assessment, reassurance, some tips on recovering, versus actually quite a good package of physiotherapy. So we were careful with, to make sure that we gave a good package of physiotherapy. It wasn't all bells and whistles. It was reflective of a good package of physiotherapy as is currently delivered in the NHS. So we allowed the physiotherapists to do certain things that we know are evidence-based, and we captured all of that. And basically what the study shows is that, kind of despite that, you can't make a very big difference to the recovery trajectory of this injury. It is on a trajectory of its own. And I think what we get caught up in, and I can imagine that I would get caught up in, is a very distressing situation. It is, without doubt, in my mind, a painful condition that's very uncomfortable. You're very exposed in the neck. And I think when you see a patient like that, your natural response as a human being is to want to help them. And, the laying on of hands and the manipulating and the exercises, all the rest of it, is part of our natural response as therapists to want to help people. And really it shows that actually it doesn't really make a big deal of difference. It does encourage the recovery a little bit quicker, but it's so minimal that the cost is not worth it. It actually costs society quite a lot of money to put the therapist in the cubicle for that amount of time, and actually they'd be better off being in a cubicle for something else. The advisory session is important. I don't think that patients should be denied reassurance and advice, and I think physiotherapists have a role there. And I think the thing about the earlier return to work in the physiotherapy arm, our sense as a trial team, as the people who develop the intervention, is that that is about repeated reassurance and message about getting back to work earlier. It's not anything really to do with a physical recovery, because we saw very little additional physical recovery, but it's about giving people reassurance and repeating the message. And I think that obviously we should give the message that people should get back to work as quickly as they can, and keep reinforcing that.
In the trial arm that was of a physiotherapy intervention, is it truly fair for us to suggest that that was evidence-based? Because it was quite varied as to what that person got. It was pragmatic, granted, but especially if we look at the outcome data for general chronic disability of the neck, which is on the up, unchanged. So we could argue that we've been pretty rubbish at it as physiotherapists for quite a while. If we were to suggest we're not making a massive impact on society there, so comparing it to what was our normal, granted it was pragmatic, but did it overinflate the outcome?
No, I mean, and we do, each trial we do is for, the question has a different angle. So the angle here was a question the NHS wanted to know, is it worth us investing money in physiotherapy? They didn't say to us, will you design a really fabulous package of physiotherapy and see if it works? And as physiotherapists who are designing the intervention for this trial, what we want to do is we want to in this trial, unlike some of the other trials, we want to encourage physiotherapists to do stuff in that time slot they have that we know has a chance of working. So, for instance, there was no electrotherapy because there is really no evidence base for the electrotherapy, and indeed there's some evidence to suggest it doesn't do anything. So it's not a great starting place. You know, it's kind of like if we suggest that to people, you're going to kind of load it really to have some failure. There is some kind of trial evidence, or there was at the time we did the study, that exercise might help neck pain, whiplash injuries, and also there was some evidence that manual therapy did. So you have to cast your mind back to when we designed the trial, and Michelle Sterling's work, Gwen Joll's work, you know, those types of pieces of work were around. And we know that physiotherapists deliver these types of interventions in the NHS. So what we did in this trial is we worked with therapists, and Esther Williamson and Mark Williams, who worked with me on the trial. Esther is MACP, MSc, trained in manipulative therapy, you know, as is Dave Keene, who works with me on other trials. We make sure that we design an intervention that is reflective of what physios do and is kind of going to maximise the potential that it could be good, and that it's reflective of every day. I don't think it's unreasonable to say that, you know, there's a good package of physio, and what I mean is that it's based on good practice. And indeed, the guidelines came out later from the CSP, and we looked and we were really consistent with what the guideline had suggested. So in some ways we were lucky. But yeah, you know, whiplash is a train that has a journey of its own.
Absolutely, and then the second part of my question being, what do you feel should have occurred off the back of that trial? Well, how should those outcomes have been interpreted? Let's go for in an ideal world.
I think if we lived in a world, and this is the world to which we are progressing, if we lived in a world where commissioning of services was evidence-based, then the commissioning strategy would have changed. I think at the moment we are protected as a profession because commissioning tends not to be at a kind of micro level, kind of procedure-related level. It is commissioned musculoskeletal services, and increasingly the commissioners are saying, oh, we would like to see this type of intervention in the package you're going to give us. But it's not like a surgical commission where we'll say we want X number of hip replacements, and I mean, I don't quite know if they get asked to give a certain type of hip replacement. So we're a little bit shrouded at the moment. One route would have been that commissioners say they're no longer going to commission packages of extended physiotherapy for whiplash. We could change what we do, because I think actually we've got quite a lot of autonomy over what we do in our departments, where we choose to put our time. And then I think there's an issue about what the insurance companies might have done. And I think that has been the thing that surprised me most with the Whiplash study, is that the insurance companies have not come back to me. Before we did this study, they were all over us, wanting to know what we were going to do, very interested in what we were doing. And actually we kept really an arm's length from them, because we want to produce unbiased research, and we certainly want to produce research that there's no question about the integrity of it. It's been interesting that after the trial, not one of those companies has ever been back in touch with us. And I don't know, kind of there's very often in the provision of treatment, there's other motivating factors that occur. So I don't know if this is what happens, but I mean, you referred to it a little bit earlier, not wanting to be litigated against. I think, I just wonder if the kind of package that happens around motor insurance and whiplash now is tightly sewn up to ensure that it's kind of watertight from a legal perspective. And, I don't know that they think it's a big enough issue to withdraw what is probably a small kind of component of their cover. I don't really know. It's really interesting. I don't know why.
It's difficult, isn't it? Because, I mean, the danger is that we've got something which suggests that it's not appropriate to sort of overly invest time in this whiplash, but then potentially there's nothing stopping people from changing the name of the condition.
Well, I think as well, kind of like we generate research for the NHS, and I know the private practitioners didn't like the results of the MINT study. There was a lot of ripples about it. We haven't produced the results for the private practice. We've produced it for the NHS. That's why we've got a cost-effectiveness analysis that's done from an NHS perspective.
On a commissioning level, I agree that an outcome of that trial should be that it would have influenced it. If I were to try and tie you down on how you think it would have influenced it, do you think it would have been a flat line, this is our best evidence that suggests it should be, only thing you should commission would be an advice session?
Now, I do now actually think that's right. I think there's a number of things that have come on from it. MINT was a very large study, and because of that, it's much more certain than a lot of the preceding studies that are done on a short-term basis and are done with much smaller numbers of patients. Small studies are uncertain. You need a big study to be certain of something. So I was confident of the results of MINT. I have no lack of confidence that those results aren't right. And again, people can pick around them all they want. That's a big, well-conducted study, and it is going to be very influential. I think what has, so that's my personal opinion. I think then what's happened, which I think makes it now, I think it's only a matter of time, is of course the Australians have produced their research, which also showed that whiplash treatments early on weren't effective, published in The Lancet. Much smaller study, but the weight of evidence of well-conducted trials with a long enough outcome of a sufficient size overall is stacking up, and sooner or later some guideline body or some commissioning body is going to look at this, and we should be thinking ahead of those, is my sense, But anyway, that's my
no, and that's certainly a great point. I think the only part of that I would express concern over is the word certainty. So certainty in science being, in this case, do you feel that line of inquiry, the idea of physiotherapy intervention for whiplash, dead in the water?
No.
In the future, it's not going to change?
No. I think the certainty lies around the acute management of whiplash. What is really interesting from the MINT study is the fact that at the end of the recovery trajectory, the numbers of people who still have problems was constant across all of the treatment arms. So there is still a question in whiplash, but it's much more about the chronic end of the whiplash scale. So, whiplash researchers, I would imagine now, are beginning to think, okay, so the acute management doesn't affect the trajectory, and it doesn't affect the proportions who ultimately end up with a chronic condition. How do we manage that 30%? What do we understand about them, and how do we manage them? And it could very well be that a physiotherapy intervention is effective, but we haven't done that trial and we haven't designed that intervention yet. That's the circle of research that goes on. So these trials, they have a life after them. They ask more questions than they give answers sometimes, but the answers are clear.
But your confidence within our methodologies of research is such that you feel that trials such as this and the ones that come off it of a similar format are such that they fairly represent society and the populations that we work with enough to make pretty decisive statements on care.
Yes, and the reason that I'm confident in that is that these trials are done, they're funded through really rigorous funding bodies. So they're funded through the National Institute of Health Technology Assessment Programme. That is robustly peer-reviewed. Every aspect of the method, of the clinical aspects are peer-reviewed, and you don't get through unless you're robust. The trials are then run in registered clinical trials units. So the trials unit that I direct is subject to substantial quality assurance and scrutiny from the Medicines for Health regulatory agencies, from sponsor bodies, from R&D departments of hospitals. So all of our procedures, for instance, around randomisation are absolutely, they're documented and they reach the quality criteria that are used for drug trials. So that's why I can be confident, because I know that the apparatus is scrutinised externally and that we comply with the standard operating procedures that ensure we deliver high quality product. And you should be basing these types of decisions on high quality evidence. It does really call into question the value of evidence that is generated out of that type of quality framework. And I know it's difficult because it's difficult to access that type of environment, and it's costly to do that type of thing, and you have to choose when to use it. That's an expensive experiment to run. Some of the experiments we run, they cost between £1.5 million to £2.5 million. You don't yield that type of money for questions that aren't important, and indeed you don't yield that type of kind of infrastructure on studies that are kind of work up towards these big things. But I think there's some principles that people should use, and I think that's another thing that the profession's got to get used to, is to eradicate low quality evidence. And we do see it. David Keene and many of the other researchers in our group are doing Cochrane reviews, and we're looking at the quality of the evidence. And it's another area where it's not even hopeful. I know physiotherapy will improve the quality of the evidence base. We're a dynamic profession and we respond to these types of things.
Even if not that I would ever want to, and even if I tried to sort of ever call into question the scientific vigour behind trials such as this, I couldn't. But the question, and I'll admit that our last podcast was questioning this very entity, was the process you've just described, where it is rigorously scrutinised, peer-reviewed. There are guidelines in place that have been used and held in high regard through pharmaceuticals, but it is historic, and it's based on the fact that is a process that's occurred within medical science. The bit where the foundations are assumed is that is the best way to go. So understandably, within the realms of what we know, within the realms of what we've come to understand of how we've got where we are in medical science, the only thing that might be a chink in that armour is that actually, how far has that fundamentally got us when it comes to complex interventions such as physiotherapy compared to aspirin? That's where it's difficult.
So I think the gold standard, this is my opinion, but it's also broadly held.
Absolutely.
A gold standard is a randomised controlled trial. It is the only way in which you can deal with a type of selection bias. So if you don't randomise patients, you don't kind of throw a dice to put them into a treatment arm, you can do all types of things, either implicitly or explicitly subvert a process. That the whole reason we randomise is so that the characteristics of patients, both known and unknown, so some of the things that we perhaps don't know about, end up being evenly spread across the different treatment arms that we're trying to compare. That is the only way you can deal with that type of bias. People try to deal with the bias through looking at observational data sets of interventions. That science is by no means there at the moment. You can't deal with things like confounding by intention. You can't get rid of this bias that comes. People decide to do something, a clinician decides to do something because they've seen something in the patient that isn't measured and available in the data set. The randomisation is the only thing that can deal with that. It spreads it between the two arms. We don't know what it is, but we know it's randomly distributed. So that is the most robust way to find out, to spread the bias. The other ways in which you can generate bias is in not having a sample that represents the population that you're trying to generalise the results to. And, we see efficacy studies which are much smaller, tightly controlled, and really they don't, they're not so worried about the generalisability. They're trying to control the variability so they can pick up signals in smaller numbers of people. When we come to large-scale trials, I think the place where I look more carefully at what a trial's done, I always look carefully at the method and, reporting what people have done in a trial is very important. But the sampling, how have they got that sample? And is that, appropriate to my population? Now, people make lots of excuses about this. We've talked quite a lot about, this is how we design this experiment. This is because, people come to the ED and this is the everyday setting and we've done it across so many centres so that we can get a generalisable estimate. And I'm happy both that the conduct of the MINT study is right and the size and the way in which we sampled means that it's generalisable. And we've looked for subgroups. People say, they recruited the wrong type of people. You kind of think, how's that? Because all these people are coming to the NHS for treatment of their whiplash. But we can have a look and we can see with these big numbers, does it matter if they were this grade of injury or that grade of injury? Does it matter if they were old or young? Does it affect the treatment effect? People will always poke holes because they don't want to believe the evidence. And we are careful. I don't know what people think we are. Actually, it's quite interesting. We are a group of physiotherapists and we engage with a much broader community when we develop interventions. And we've worked in the NHS. Some of us continue to work in the NHS. We're not that different. So I kind of think it's nitpicking.
Yeah. I think and we would never be sat in front of you if we were sort of evidence nihilists. However,
you could be. I don't mind.
Maybe, perhaps. It'd be a pretty dull channel, and we don't necessarily think we'd have many listeners. But we don't bang this drum excessively. However, and I'm going to move on from it because our last question is a really good one from Rob regarding regulation. But generally, just to tie up on that is your absolutely fair and sensible rebuttal to what I said was that RCT is the gold standard. As humans, we made it the gold standard. Is that something that at the moment should not be questioned? Because we essentially put it on a pedestal. Are we therefore not allowed to shake it?
I think, of course, we're allowed to shake it. And we do shake it. So in my broader role, where I'm involved in commissioning research right across the NHS, we regularly shake it because it costs a lot of money. It's regulated, it's costly, it kind of adds steps in that aren't always easy to deal with, and but it is the only way to get rid of this bias. You cannot do it any other way. We have no proven alternative. And believe you me, there are plenty of people thinking about it. I think as well, it's important to remember that research is done at lots of different levels for different reasons. And I know quite quite often people will say to me, oh, well, the qualitative research will show you whether or not this works. Really interesting. I have a colleague who is a very fierce advocate of qualitative research. I don't think she'll mind if I mention her name, Trish Greenhalgh. She's really a very strong advocate. And I also advocate qualitative research when you're looking to try and track what the experience and the feeling that people have about either their condition or a treatment is. But even Trish will say that if she is going to go and have a cancer treatment, her decision is based on a randomised evidence about what delivers the survival benefit. Absolutely. And that says it all to me.
No, it doesn't, and for sure. And this is that caveat of there being a place for different methodologies.
Yeah,
and that's absolutely the conclusion we did find ourselves coming to on our last episode.
Does all this disparity between research findings and clinical practice reflect a lack of true regulation within physiotherapy compared to that of, say, Ofsted within education?
Said it were good, then.
Yes. The NHS is a very large organisation, and we are lucky, I think, I talk as a therapist, not to be under incredibly close scrutiny. But scrutiny is coming our way from a number of different places. I don't know how long it might take, and maybe it may never happen, but I think it's a possibility that at some point the regulators are going to start to the regulatory environment will start to pick up on the fact that we are self-regulating, and they may be very happy with that. I don't know what it will bring, but I think that potentially that also may change things a bit for us. So I think I see us as self-regulatory at the moment, and I see that could change.
I see that as a positive, but I see the flip side of it as a negative, in the sense that I sometimes think that do no harm is not enough.
No, in my opinion, it's definitely not enough. It wastes taxpayers' money.
Yeah, and what we define by harm is that that intervention is not injurious to that person, but it's not necessarily going to improve them the way that another intervention could. And when we've got certain bodies who are sort of advertising reflexology, Reiki, energy medicine, electrotherapy on quite a wide format for physiotherapists to look up and go, well, if this particular body is promoting this, then maybe that is something I need to head towards. Do we not need a bit more refinement rather than this self-regulation that we should be looking after ourselves, but actually we're probably not doing it as well as we could do, and we do need a little bit of guidance on that. And I know that's where research comes in, but when it comes back to the original question, is how accessible is research to somebody on the front line?
I think that we are all moving in the right direction. So I see great strides now in the Chartered Society of Physiotherapy, and a kind of reinvigorated perspective on evidence and engaging with policy. So I think that's really good, because I think the professional body is important, and I think it is collective, and I think it has the potential to be the most sensible route, and I say potential, because I think also, we have to change, and I think that is changing, it's not the same professional body that it was 20 years ago, so that's really good.
Can we distance ourselves from our own biases, or are we doing that right?
Well, I think I would encourage every physiotherapist who goes into a cubicle to think not only as a physiotherapist, but as a taxpayer. And I think if you can keep that perspective with you and remember that, out of your pay packet goes a substantial wad of cash that goes over to the NHS, and I as a taxpayer want to know that that is spent wisely to the maximum benefit. And that is something that each of us should carry with us, and we shouldn't forget it when we go in the cubicle. We just shouldn't.
And beyond just as a taxpayer, as a private practitioner, you should be thinking that this person is parting with their hard-earned cash to a higher percentage than, say, tax for an arbitrary number of 6 sessions of intervention X,
Yeah.
is that necessarily something
Yeah.
that's value for money?
Yeah.
I mean, there's been a few episodes where this has come up. We're going to be called out for having a massively socialist agenda, I think. There's a few things that have sort of tapped into that. Is that we've got to think socially about what the bigger picture is and how we affect society.
I think that's a professional, issue. I do think to be wise custodians, if we are wise custodians, we are more likely to be allowed to be self-regulatory. If we are not wise custodians, we will not be permitted. That will tighten eventually. It's just a matter of time. And I think this issue of wise custodianship is really an important one.
It's probably a topic for another podcast.
Absolutely,
as well,
I'm sure it's something that is going to be born out of your debates at Physio 15.
If I can still talk.
If you can still talk, we've sapped every last bit out of your voice, I'm afraid, today. Compromising your debate.
Yeah.
So, yeah, sorry about that. Thank you so much for your time today. That
It's
really
been a
wraps us
pleasure.
up. One thing that we do is we try and make sure that a lot of the literature discussed, all of the literature discussed in this podcast is made available through our newsletter through to our listenership so that they can get the hard science and make their own interpretations of that based on what we've discussed today. Is there anyone particularly that you'd like to mention that hasn't cropped up in conversation, or anything you'd like to direct the listeners to of your work or otherwise?
I've got a cast of thousands to thank. I think
Oscar speech.
Yeah. Actually, what I'm going to do is I'll take the opportunity to thank all of the physiotherapists who have helped us to run these trials, all of those people who have gone out of their comfort zone and done things for us that are really, they're really so important. We cannot run these trials without those people. And I'm truly thankful to them. And I'm also truly thankful to the patients who also agree to, kind of go into an experiment. It's a very significant contribution at both levels. So, yeah, they're the people who I will really thank.
Fantastic. No, that's lovely.
And so that was yet another podcast with Sallie Lamb following our interview. Feels a long time ago, doesn't it now, Rob?
Yeah, that break's been a long one. 4 weeks sitting down Oxford was a long time to kill.
Yeah, but we've had people banging on our doors and metaphorical doors on social media, of course, demanding the part 2. So I hope it's delivered. People fairly keen to hear, particularly the answer to the cliffhanger.
Yeah. I think it's there for people to make their own mind up, and I know people will be coming in with their own biases, listening to the podcast to hear what Sallie has to say. But it's certainly worth considering things from the other side of the argument and challenging your own beliefs to really shake things up.
Well, we tried, didn't we? I think with the protocol thing, so that's where we left the cliffhanger, wasn't it? Was me suggesting about the protocol, and we danced around it, and Sallie quite understandably turned towards protocolization of clinical trials, and we then tried to extrapolate that into practice and talked about general accountability, how that's influenced by both autonomy and evidence and things. I think is it fair for us to say that's a question that can be probably posed elsewhere? It still goes unanswered.
Yeah, definitely. I think it's maybe only scratched the surface of the topic, and of course we've got to understand we're asking Sallie, who's very involved in clinical trials, to tell us a little bit about why we should use clinical trials.
Yeah, for sure. And the way that the conversation then came to, and quite rightly so, was regarding the large piece of work that she'd done with the MINT trial. So we started to then lash into Whiplash. Your thoughts, if you don't mind, on what we chatted about, especially now that the dust has settled and we've had a chance to listen to it back and things like that. What are your thoughts?
It's a tough one, really, because I think we've chatted off mic recently, and even when we're down the Therapy Expo, about where we stand on these kind of things. And I just find it very difficult to treat a pathology when we know that there are huge psychosocial implications with every person that walks through our door. That doesn't mean that, as Sallie was suggesting, some people are an evidence-based nihilist. But I do think you can't just blindly follow these protocols, because, as you quite rightly said, that it gets rid of a bit of accountability. And going back to her original point, she mentioned that it takes 19 years for evidence to enter practice. And I just wonder whether that's ever considered when we're doing studies on, in inverted commas, current best practice, because realistically then aren't we assessing what is, in effect, 19 years out of date?
I love that point. Absolutely love that point. I'm glad you've brought that up, because that is exactly it, isn't it? This idea of and we said about this. It was a pragmatic account of what goes on. However, we can't be massively proud of what goes on. And I touched on it. If we frame it that way, we've got a really good trial that studied 19-year out-of-date practice versus as an advice session, and then we all need to be surprised when that shows that it's not effective. Now, the difficult part is that I think that clinically we both find ourselves somewhere nearer the trial's conclusion than we do to historic treatment or what is common treatment of whiplash. And so we don't want to act like we're trial bashing here at all. It's incredibly, and I'll admit, it's been an incredibly influential piece of work on my practice, because it really did make some pennies drop.
I'd have to say that, from an evidence point of view, it may be nice to have not just RCT at the top of the pyramid, but have things on an even pegging, whereby you have a topic, you assess it from an RCT point of view, as Sallie quite rightly said, to distribute bias across a wider population, but then also go down a qualitative route and follow up on those results and see why we've got these results, and maybe then grab a handful and do some case studies on that. And it should be a process of study, I think, rather than a ticky box RCT done, cool, answer collected.
Yeah, and I think that's absolutely right, isn't it? It should breed more questions.
Take the patient off the conveyor belt, and it's that shared decision-making process. See the person the first time and discuss, look, these conditions do settle down, as Sallie mentioned. They have a shelf life, they have a natural process they go through. Physiotherapy can be there to potentially smooth your journey along that way, but we're not realistically going to speed the recovery up.
One of the
what
things,
would you like to do, and would you like to come back?
That's it. But then when we're talking about this trial was designed as part of a answering of a health economic question, and in doing so, and I think it answers that fairly well, particularly with the other studies that have come to similar conclusions elsewhere in the world, is that generally speaking we don't influence its trajectory so much. But what it does is we know that there's certain techniques that physiotherapists have long used that offer relief of sorts. They feel pleasant, and sometimes patients in these situations want it to feel nice. Now, here comes the difficulty: is that if we're to take away the fact that answered a question for the NHS, and I think it does so well, in the wider practice of sort of private work and other little sectors, there is a race to the bottom, isn't there, with regards to cost and people being squeezed out of it.
Yeah, but it seems to be the case across the country. You hear the prices dropping.
But you can sort of understand it, because why wouldn't it? Why wouldn't it need to be cheaper and cheaper and cheaper? Because we're then competing with masseuses. Because essentially, when it comes to whiplash, to conveyor belt whiplash care, which is a huge section of the private sector, it's enormous. The vast majority of some practices.
But we're assuming that is the treatment of choice, though, the mechanical-based treatment of choice, and what potentially I feel physiotherapists have to offer is the wider scope of the biopsychosocial model, rather than just, I'm going to give your neck a rub.
Yeah, well, and I'm going to agree with that, but also, do you think it's a bold assumption of mine?
No, definitely not. Definitely not. And I mean, I can only speak from anecdote and from experience, and that seems to be a pathway of management. 6 sessions of insert intervention X here, as opposed to really sort of deconstructing and getting to the nitty-gritty of the underlying issues, as we discussed off mic, the hardships of people being off work, the hardships of having a hire car, or potentially being responsible for a passenger who was also injured in the crash and feeling responsible for something that was quite likely not your fault. I mean, there's more than just the tissue going on here.
Yeah, and this study being maybe redone in 19 years' time, perhaps we can. Well, no, it's a 3-year-old trial, isn't it? So let's not be silly. Let's make it. Let's go 15 years to be generous, and say that we'll redo the trial in 15 years' time and see what might have happened. Because strangely enough, whiplash patients still see physiotherapists in all sectors, and so weirdly little has changed in a lot of ways. And I think that was sort of touched on. And I think Sallie's in a funny position to not want to say that outright. Which is kind of good. I'm glad. I don't want us to be having sleepless nights or frustrated. But equally, I think as clinicians, we've got an awful lot to answer for when it comes to something like this.
Yeah, for sure. I mean, I think when you have to look at the iatrogenic effects that sometimes contact with a therapist or healthcare professional can have, and you're dealing with sometimes people who are in a particularly vulnerable state and in a suggestive state because they maybe have been sent to you from the solicitor, as an expert in this field. So your expectations are, as a patient, that you're going to see this person who has the answers, and whatever you say has some quite large implications.
Yeah, for sure. Absolutely. With regards to the latter part of the chat, we started to natter a little bit about generalised regulation of the profession. But generally, one of the things I took from it, which I've used since in lectures and elsewhere, is the idea that one way we can better peer regulate would be for us to stop thinking so much as physiotherapists and start thinking at least as much about being taxpayers and wanting the best bang for buck. I thought that was a really interesting point.
Yeah, it's a strong point, and it's something that I probably haven't thought of much as a junior physio, but the longer you're in the game, you kind of start to have a bit more responsibility as you get a bit older, paying mortgages, checking your pay slip for how much has been taken away, and start to recognise that actually, you are contributing to society, and what you do is effectively having an effect on the pot of money that exists.
But we'll chat about that next time, get that recorded, and have that out in January. But
look forward to it.
Yeah. So, but until then, thanks a lot for your work on this.
No problem. Thanks for having me.
No bother, and we'll catch up soon on the next episode with the rest of the gang. Final plugs from me. Huge thanks again to Sallie Lamb, David Keene, Anthony Gilbert, Ash Shattock and the ATOCP. Find them on Twitter at Physio ATOCP. I can highly recommend getting involved with them, having met a great bunch down at their annual conference a couple of weeks ago. Some great feedback from listeners at the Therapy Expo, which we attended as a five-a-side team. Thanks to everyone that joined in with the sticker mischief. Follow at TPM Podcast on Twitter, the Physio Matters Podcast on Facebook, and brace yourselves for next month's episode, which is called Physio Doesn't Matter. And no, I haven't fluffed my lines there. See you next time. You've been listening to the Physio Matters Podcast, discussing physio matters because physio matters. Or does it?